after the basic knowledge and a good introduction to OSD, we are happy to move forward to the second session. And we'll start with the modern diagnostic approaches. So I invite Dr. Robert Shetty for advanced tear film assessment technologies.
Thank you. After a wonderful morning session, I'll just go into basics and advancement of tear film technologies. These are my financial interests. I always look at tear film as your phantoms of your vision, because that's something which is existing but you don't see. And dry eye, we have seen in the previous session, so I'll not go into the depth of all that it can do when you're not managed, especially when you're looking at in an ocular surface post-refractive surgery. So let's look at what options we have to study the tear film. Let's start with the clinical aspect of it, the questionnaire, TBUT, the Schirmer's and osmolality. And we know that many of the discomfort score does match with the TBUT. So that means having a good scale, like an OSDI, is very important. We have interferometry and also the meibographies from the keratographs. And if you look at a good tear film, you see it has multiple colors. These colors have been looked at, how you evaluate this. And you have the metrics which is given out here, a good and a poor metrics of ocular surface. And you correlate this with the quality of tear film, and you see this is what happens to your quality of your vision. Imagine you put a multifocal lenses and the patient comes with glare and halos. The glare and halos or neuroadaptation may not be linked to your multifocal, but may be linked to your quality of your tear film itself. There are there are LipiFlows and other procedures which helps to see improvement in your tear film given by this matrix numbers out here. Clinical examination of the quality of meibum, the secreted glands, is very important. The type of meibomian glands and its dropout helps to look at the quality of tear film itself. Now we have some beautiful assessment from the keratograph. We call it as the Genvis report, which looks at the meibography, the non-contact tear film, the lipid layer, and it says the inflammation quotient based on redness and conjunctivocalysis, and also the tear volume. And finally, it gives you a quantification score, which is healthy here, which looks at all this. It has this quantification score, which does its own analysis. And if it's bad, it gives you a score like this. So in one shot, you measure the entire components of tear film from lid, meibomian glands, and the non-contact breakup time, which helps in big way to create and see what is happening to your tear film assessment. The optical quality assessment system looks at the tear film as an optical system from the first blink to the last, from the in-between blink time. And you can see the quality of tear film is bad. It means that it's not good enough for the optical quality. So it's very important to look at optical quality, especially when you're dealing with refractive surgeries, premium lenses, when you do an EDOF and other changes which can create this change, which can create an impact. We have been working with the oculists. We are working with them closely to develop a software, ocular OCT, to look at every layer of your cornea. And that's one of the things which is going to be launched. It's already launched in ESCRS. What it does is, it does a quantification. This is something which we worked with our own team. Quantification of your tear film, your epithelium, and also you can really divide between the layers of epithelium and your Baumann's, the stromal, and the Descemet's. And this quantification happens automatically. And once this quantification happens automatically, you're able to generate the first report is your tear film itself. So this is the quality of tear film. We had wonderful talk speaking about meibum and what it contains and how it has an impact and how the lipid layer has an impact. You can look at different types of tear film and how it has impact. And if I correlate that with your OCA system, this is a OCT and it gives you that. And if you correlate, you can see the impact of the tear film to the quality of vision, which has a huge role in looking at how your tear film becomes an optical system. And in your talk, you mentioned that the refractive tear interface has probably it's like the air and tear film has the most refractive change. And this gives you an impact on how it's going to be impactful as you move forward. Even though I'm not a very big fan of this, but osmolality of tear film helps to look at the inflammatory status. It also has an impact on understanding the change. And there are a lot of studies being done on impact of osmolality in IOL formulas, post-operative care, and other things. And these are the normal values. And for some reason, it didn't pick up. Maybe the repeatability was not great. But if somebody works on it, probably we might get a tool which looks at osmolality in the future. Vitamin D, I've worked on it, and the vitamin D receptors have a huge role in the way the tear film works. And even the TFOS New 3 also talks of the vitamin D. And what is important is it's not the vitamin D, but the lack of receptors on the ocular surface. And we did work on looking at the vitamin D receptors using conjunctival impression cytology on the cornea and looking at and staining them. And what we feel is you may have a very low vitamin D, but you may still not suffer from a dry eye because your receptors may be completely healthy. But there are people who have a very high vitamins in the blood, but inflammation knocks the receptors. That means high MMPs, osmolality. If you have a high osmolality, the first thing it does is it just knocks it off completely. So role of vitamin D and how do you improve it through inflammatory, anti-inflammatory methods is a very useful tool. Confocal microscopy talks about the pain without stain and many aspects of the disease. We started looking at confocal microscopy for many years, and there's a healthy nerves, and these are your dendritic cells. But recently, there's been paper from New Zealand which talks about that these are not dendritic cells. Some of them, they are T lymphocytes. It's very interesting because dendritics are the ones who have a lot of tentacles, but ones which does not have. And if you actually measure them over a day, you can actually see them moving. That means this T cell can become here or come here. It's very interesting to see them change. So confocal microscopy actually can help you to see the T lymphocytes. It correlates with your quality of vision and your tear film. It correlates to a microneuromas out here. And there's one patient where we published this microneuroma also caused so much of inflammation, it actually eroded your Bowman's. And this patient had chronic pain. So if you look at OCT and microneuromas, you can actually pick up why sometimes people with very strong pain have a very thin Bowman's, because microneuromas secretes IL-17 and a lot of other IL-6, because these things actually can erode your Bowman's layer. And there's a paper we published looking at discordance of pain without stain to the confocals and T cells. And we have to use right terminologies now. And what's interesting here is the epithelium is a surrogate marker of what is happening to the confocal. A healthy epithelium has healthy nerves. As the epithelium becomes poorer, you can see that the confocal also is bad. So epithelium, if you don't have confocal microscopy, you look at the epithelium and it tells you the state of health of the eye, because it will tell you the state of immune changes happening underneath. This is a work we did. This is holotomography of an epithelial cells. These are all your Golgi bodies, all your cells. And look at this. Then you create a desiccation stress. You create a stress, the cells don't function. I use Trihalo's-based medications. These are lysozymal trackers. These are like tracking enzymes which creates the metabolic health of your eye. You can create a lot of our work of ocular surface is using these cells. And you can see how a dry eye kills these cells, and you can see them dying. And this is autophagy, a cell eating itself, a dead cell eating itself and digesting it here. And most of the time, the cells don't eat the dead cell. When you don't eat the dead cell, you end up in an autophagy imbalance. Here, look at that. Every dead cell is eaten up, gulped it. These are enzymes. These are like your kitchen cleaner. They just cleanse your kitchen so that there's nothing dirt left. And if you don't have lysozyme tracker, your tear film and ocular surface is never going to be healthy. And this ocular surface, I mentioned, the need of ocular surface health keeps the epithelium on. A good health of epithelium, whatever surgeries you do, brings the epithelium back to track, and the corneal nerves also recover faster. So tear film is just not about the dry eye, it's about healing. It's healing about corneal nerves. The inflamed tear film never allows the epithelium, the corneal nerves to heal. You can see if you have a pre-op contact lens wearer, his healing is much slower compared to a healthy, non-inflamed eye. Ion channels are ones which are coming up in a very big way because it is nociception. And in one of the talks, it was mentioned that pain without stain and the concept of neuropathic pain. The neuropathic pain and central sensitization happens because your channels which are there with your sodium, potassium, and these channels are the ones who don't function at all. And once they don't function, we have different receptors for it. And there are patients, the majority of unhappiness in a post-surgery patient today, after any surgery, is because they are nociceptively more driven. And the nociception increases in patients, sometimes with using excess paracaine, the proparacaine, or betadine, because both of them impact these channels, which is sometimes which is not seen. And these things have been implicated in dry eye, and we published this work. Alcon has come out with a new drug, the TRP8 drug. What it does is, the TRP8 is a drug which gives you a cooling feeling. It's like taking menthol tablets. So that's how you trust the TRP. TRP is transient receptor potential 8 channels. So if you put a drop, it gives you cool feeling like putting cold water in your eyes. That's the way the dry eye is moving towards. And these are all the receptors which I wanted to talk about. And this is what happens when your cornea nerves are cut. And then what happens to those ion channels and what happens to your ocular surface fluid. The molecular factors have been briefly mentioned, and I'll be quick because I have a talk on this in the same session. So I'll just say that I'll just skip a few slides because I can talk about in the next session. I can say that we started looking at molecular factors as the major areas of interest, and thanks to Dr. Mohammed who spoke about it. And all these factors have been implicated in many, many aspects of ocular surface and retinal diseases. And we started looking from a Schirmer's plate using a microfluidic design, which we developed it ourselves. We were able to bring it out in 90 minutes, this report. And this is how it works. And there is something called as a 3 times it gets the antibody antigen reacts here, and 3 times you can get a fluorescence, or the machine repeats in triplicates, so that it's not one report and you get one report which is variable and you take the report. So that is one of the most unique aspects of it, because it's repeated 3 times to see if it's really there's a change. And I can play this video later. And we developed based on 10,000 dry eye sample. We've been working on it for 17.5 years now. And based on that report, we have an AI which has a normal values, and it tells you and you can put anything to it. You can put an aqueous, vitreous, fine spinal fluid. You can put blood, and if you create a normal values, you can actually get this report. And this is also how the report looks. And based on that, we are able to look at a lot of drugs which can be customized. And this is what is interesting, is that you can customize it like how you customize an antibiotic sensitivity. We use the same format to customize the cytokine sensitivity of these drugs. We don't have too many of these drugs which act. For example, there's not too many works on IL-6. We have lifitegrast which works on ICAM1, but we have many more in the pipeline which can work. And this panel can be expanded. You can expand to 24 more cytokines, tomorrow even 100. But all it needs is one Schirmer strip and the proteins which can be leached out of it. All I'm saying that using this kit, you'll know how the treatment works and how you can titrate your treatment as you move forward. So the whole concept of imaging of dry eye is to try to find out what happens to all of these things which have an impact on your quality of life. Dry eye is not just a fluid, or a tear film is not just a fluid out there. It just changes the way you live your life with or without surgery. And the 99% of our surgical patients who are unhappy because your tear film is not great. Thank you.
Thank you very much for this excellent lecture. And in the meanwhile, may I invite the speakers of this panel to the front row?